thank you all very much for allowing me to come here and to share with you. This is greetings from the state that I live in, the city of Chicago. Where I live in is you get in from here, you drive 3 hours south through cornfields. There's nothing to take a picture of except corn, so I thought the city of Chicago looked a little bit better. As the chairperson mentioned, cancer now, as you know, is the #2 cause of death in India. And screening for cancer is a very important thing that as primary care physicians that we have to be at the front role. But not just mindlessly ordering cancer screening, but understanding cancer screening. My objectives today are to talk about cancer screening as a concept first, talking about what are the pros and the cons of screening for cancer. And that may surprise some of you, but hopefully by the end of the session that will not surprise you that there are cons for cancer screening. We're going to talk about what makes a good screening test. We're going to critically assess some of the accepted cancer screenings. And these are all conceptual things. And at the end, we're going to talk about some of the leading cancers and some screening strategies that are evidence-based in India. So here's our first question for the audience. The statement, early detection of cancer is a good thing. How many agree? Raise your hand. Raise them high. How many disagree? Anyone disagrees? How many are unsure? We'll come back to the answer to this question in a bit. But for patients themselves, there's no doubt. This was an interesting survey done in JAMA in 2004, and of the thousands of people surveyed, 87% believe that routine cancer screening, along with you all, said that it's almost always a good idea. 74% of them said that early detection of cancer saves lives most or all of the time. In fact, their enthusiasm was so great that they said 80% of the people surveyed said that if you were an 80-year-old person and you declined cancer screening, that you were irresponsible. That's how enthusiastic people were for cancer screening. We're going to think a little bit today. You're the patient in the clinic, and here comes a 55-year-old healthy patient. I just want to stop here. We're talking about screening. And so screening means by definition the patient has no symptoms. They're healthy. Okay? We're not talking about someone with a lump or a mass or some complaints. They're completely healthy. And they come to you and they say, Doctor, I'm worried that I have cancer X. And I want to know whether you would recommend for me to have this test. So as you can see here, that the 5-year survival rate without the screening is only 69%. The 5-year survival, if you get the screening test, is 99%. Do you recommend this test to your patient? Raise your hand if you want to recommend. Have some yeses, some no's. My next question is, does this test save lives? Can you raise your hand if you think this test saves lives? No, some, yes, no. Cancer B, this guy's twin brother, comes to you and he says, I hear that I'm worried I have a cancer B. And he wants to be screened for this cancer. The mortality, the risk of dying from cancer B over 5 years without the screening test is 2 people out of 1,000 healthy people will die. If you have the screening test, only 1.6 people will die per 1,000 lives. So the question is, how many people will be saved if you screen 1,000 people? Someone shout the answer. It's 0.4, right? So do you recommend this test to your patient? No. Some yes. So of these 2 cancer screening tests, which one is better? A cancer screening test that improves your 5-year survival rate by 30%? Or a cancer test that decreases your mortality by 0.4%? The first one. So hopefully by the end of that, I'll help you to all realize that that's not true. Actually, these are both statistics looking at the same test. And they're very different. So one of the things that I want to do together today is to talk a little bit about some biases that come in and how cancer screening can actually become harmful to our patients. But first I want to hear about your experience. What are some of the cancer screening that you do in your practice? Mammograms? Pap smears? Okay. Anything else? Colonoscopy, colon cancer screening? Yeah, CA-125 screening for ovarian cancer. So how do you decide which of these tests to order? Yeah, you base on family history. But again, screening is, it depends on the population. I think one of the interesting things is that thinking about screening for cancer in India really is a challenge because we have very different populations of someone who's living here next door in Johor Bahru here in Delhi and someone who's living in a village in India. Can you use the same screening cancer guidelines for both of those populations? I see a lot of people shaking their heads no, and I would agree with that. So the question is, can cancer screening harm anyone? Yes. I like the enthusiasm of that yes, because that's the true answer. Not all screening tests are equal. And I'll just tell you that improvement of 5-year survival rates is not enough, and we'll come to that in a second. But how can screening cause harm? So actually now most modern mammography machines are very low radiation. So the radiation risk used to be a significant one. With newer machines, it's almost minuscule. False positives. We'll come to that in a little bit. What else? Cost. Cost is huge, right? So we're going to talk about some 4 concepts. And I know that these will seem esoteric to you, but I think that you'll find them interesting, and I think that they'll help the rest of our discussion. So this is any cancer here you can see, and the cancer will be progressed from a disease that you cannot detect at all to a disease that has no symptoms but is detectable by screening, one that now has symptoms, a lump, bleeding, and then one that is metastatic and incurable, and over time. And so we're going to do screening at certain intervals in this person's life looking for this cancer. And tumor A, you can see here, do you realize that a lot of us have cancer in our lives and will never be detected and will never cause us any trouble? So that tumor is non-detectable. It will never be detected and it will never cause trouble. The second tumor can be detected by a screen, but this cancer would have never ever provided symptoms in a patient. Cadaver studies in Europe done of thousands of men over the age of 60 revealed prostate cancer in over 60% of them, but it never affected them in their life. So for this is what we call overdiagnosis. Overdiagnosis simply means finding a cancer that would have never affected the person in their life. The third cancer is one that's detectable by screening and would have gone on to harm the patient. And then the last tumor we have here is one, and unfortunately these do happen, that come on so quickly that before you have the next chance to screen, it has become metastatic. These are what we're trying to find here, these screen-detectable cancers. So overdiagnosis was the first thing that I want you to know about. The second one is an interesting concept called length time bias. And so, all tumors can either be an indolent tumor that just lingers around for years, or it can be a very aggressive tumor. And so all of these tumors will start at some point in their life, and at some point they will become detectable by a test. The more aggressive tumors will become detectable more early, and quickly then the symptoms come. But you can see that if at any given time you're screening for a cancer, you're more likely now to pick up these indolent cancers, right? Because they're around for a lot longer. And so all screening tests are more likely to pick up those cancers that would never harm us, like the prostate cancers. The last concept, or the second to last concept that we'll talk about, is lead time bias. And you'll find in a second here why this is important. You may be thinking, why are we doing statistics again? So here's our control group here. And they go along in their life and they develop a symptom. Maybe it's a lump in the breast. They feel the lump in the breast, they go to the doctor, the diagnosis is confirmed by testing. The patient is treated, but eventually this patient dies. The time before their diagnosis is made and the patient dies is their survival time. But here we're screening the next group of patients, right? And we find the diagnosis before they have symptoms. But because this is a complicated cancer, or because of the test being, the treatment being difficult, this patient dies at the same time as this patient. But we've increased their survival time by a huge proportion by screening. But can you see here, and we call this the lead time. All we've done is cause this patient to live more of their life with a diagnosis of cancer, but they're not living any longer. That's why increasing a survival rate, when you see in a literature or whatever that this cancer test improves your survival rate, if it does not improve your mortality, it's meaningless. The person is just living longer with the cancer, but they're dying the same time they would have otherwise. So here's our last example. Without screening, we find 1,000 people who show up with symptoms for a progressive cancer. 5 years later, unfortunately, 40% of them are dead. the 5-year survival, or 60% of them are dead. So our 5-year survival is 40%. With the screening test, we find a lot of those indolent cancers, those ones that would have not affected the patient. We find 2,000 of them, non-progressive cancers. 5 years later, now we have a lot more people who are alive, but of that same proportion of those aggressive cancers, the same portion died. But we've made our statistics look great. With this screening test now, we have 80% 5-year survival. But we haven't really changed the outcome of those initial people with cancer screening. This is also an example of overdiagnosis. Okay, and then we're going to talk about false positives. You're all aware that any test you do for anything can have a false positive. That depends on the sensitivity and the specificity and the prevalence in the community. False positives are very significant. So if improving 5-year survival is not enough for a screening test, what does a screening test need to do? It has to be shown in a randomized controlled trial to reduce mortality. So what's a good screening test? You all know this from your epidemics courses. So the disease has to be one that's of significant seriousness in a society to want you to screen, right? And the treatment of that disease has to be better before symptoms start than after the symptoms start. It has to be inexpensive and easy to administer, reliable. So here's a bad example of a screening test. And I chose this example after reading the newspapers and looking at statistics of PSA tests ordered in India, especially in large urban areas. Unfortunately, PSA testing is on the rise in urban areas in India as it's being phased out of testing in the rest of the world, and this is why. So the United States, Canada, UK, all of them now do not recommend routine PSA screening for the population. We're not talking about people now who are high risk, no family members, just the routine population. Why is that? Because they have decided that there is moderate or high certainty that harm will outweigh benefit. So how can there be harm from just ordering a simple blood test? I mean, it's just a blood test. Costs a couple hundred rupees. We find that it's high. The patient goes for a biopsy. But the reality is for every 1,055 patients you order a PSA screen on, 100 to 120 will have a false positive. That means the test itself is positive, but the patient has no tumor. So now that patient is sent on for prostate biopsies and everything. 110 of those will have some kind of prostate cancer. 60 of them will have complications from treatment, from the prostatectomy. 4 to 5 of them will die, and 5 would die in the control group. So we've saved 1 life from a screening test. Breast cancer is unfortunately not that much better. For every 1,000 women over the age of 50 that we do breast cancer screening on, about half of them will have a false positive. 3 to 4 will be overdiagnosed. That means that we find a tumor that would have never progressed, and we will save a life. Approximately between 1 to 2 women will avoid a cancer death. But the cost, what is the cost of doing 1,000 mammograms? So there are downsides to screening. We're going to get to the good stuff in a second here. But I just want you to remember this. Every time you order a CA-125 or a PSA or a mammogram or a colonoscopy, to be thinking that it's not always the best thing. And so what are some of the downsides? We've talked about the overdiagnosis and false positives, to the harm of that individual by being labeled. So there's a very interesting paper in the Journal of Family Medicine in the United States in 2013, and it looked at all the women who were told that they had a lump. And they went on to further screening, and they were said, oh, don't worry, that lump is it's not a malignant tumor, it's just a benign fibroadenoma or whatever. And they followed those women for 3 years. Unbelievably, that those women had more trouble sleeping, more rates of depression, more worry, more relationship troubles within their marriages, more visits to the doctor. And you wonder why. They were told it was not cancer, but that doubt has been planted into their mind, and they were being labeled now as someone who was sick. The other problem with overdiagnosis is that it takes all those resources treating those people who are overdiagnosed, and it takes it from doing other things in the community that have a bigger benefit, and it draws attention away on a large socioeconomic scale from things. Do you know that in the United States, to save 1 life from cancer costs $228,000 to save 1 year of a life from prostate cancer screening? And what do you think that costs here? That's not a cost that can be sustained here by this health system. So stop doing PSA screening. Downside to treatment, you know that 0.5% of men will die within 30 days of having a prostatectomy. Many of them will become incontinent, you know this. And one person, for every 3,000 people you screen, one man will die from treatment complications. So even the urologists in the United States don't recommend PSA screening on a broad scale. And I just want to show you that not all cancer screening tests are equal. Prostate cancer has been proven, red, you can't see that here, to be bad. Breast cancer we still do, but there's increasing, if you read the literature, concerns about breast cancer screening because of all of the false positives. Lung cancer screening has a star by it because that's not something that would happen here, even though it's a huge cost. Colorectal and cervical cancer screening, more benefit. One question. So there's a question about how many of us order tests on our patients without talking to them about these downsides. And unfortunately, this was a survey done of family physicians in the United States. And you can see that almost 50% of them either ordered the screen without ever talking to the patient or just recommending the screen without letting the patient decide. So we know this already, that screening is an asymptomatic person. A good cancer screening test saves lives. They do save lives. Cervical cancer screening saves lives. When we talk about cancer screening guidelines, you'll never learn them once and walk away and know it for the rest of your life because they're always changing. Why are they always changing? Because the prevalence in society is changing and treatment options are changing. And I just want to warn you, India should never blindly adopt cancer screening guidelines from the Western world. Why? Because in every cancer screening guideline, there's not only data, but there are assumptions and cost effectiveness data that may not be applicable for this population of patients. You know, this is a chart that's probably very common to you, the prevalence and mortality of an article published last year of the cancers in India. You can see breast and cervical cancer are at the top of the list there in prevalence and also in mortality. I tried to find online, now this is where I'm getting out of my water here, because I'm not practicing medicine here currently. But this is one of the best articles I found after doing extensive literature search. This was published this July in Lancet Oncology, and it was a conglomeration of several cancer institutes in India getting together with some people from the National Cancer Institute from the United States. And they looked specifically at 3 cancers in India that are very high. Lip and oral cancer. You know, and the people who are shouting out here, I didn't hear anyone talk about visual inspection of oral mucosa. But yet oral cancers are the second most common cancer in men in this country. And when screening population studies were done in India, 81% reduction in mortality by just looking in the people's mouth on a regular basis. Now, those have to be high-risk people, alcohol and tobacco smokers. So the recommendation is that every 3 years there should just be a visual inspection of your high-risk patients who are aged 30 to 60. If you see a lesion that looks white or suspicious, you can add some toluidine blue dye or acetic acid wash and re-examine that. And the other thing is, in this population of people who drink and smoke, and they're also more likely to have other cancers, right? So it's a great way to screen for other comorbidities like heart disease. So every 3 years, screening and just looking in the mouth of high-risk patients, those who smoke, those who consume alcohol. Cervical cancer, the second most common cancer in this country. Very amenable to screening. Why? Because for the time that HPV virus affects the cervix until it becomes cancer is a very long time. And so there's ways to change it. The WHO, many of you are familiar with, even though pap smears were mentioned, visual inspection with acetic acid with or without visual inspection with iodine, Lugol's, reduces mortality in developing resource-limited countries by almost 35%. And that's the current recommendation for the WHO. But one of the things I want to put in your mind, why do people get cervical cancer? One reason, right? HPV. There are no cervical cancers are very, very uncommon that's not caused by HPV, which is a sexually transmitted disease. There's a very interesting study done in Maharashtra, a 7-year follow-up of a randomized controlled trial where all they did was HPV screening of vaginal samples in women. They decreased mortality rate by 48% and stopped aggressive cancer by 80%. And then in the future, we're looking at the affordability of HPV vaccination in India. It's still very expensive, but the WHO has said that even though it's expensive, the government of India should consider it because it's ultimately going to treat the main cause. I see my time is up, and we won't have time to get into the most complex one of these, which is breast cancer, with the #1 screening cancer in India. Self-breast examination is not recommended. Formal education for self-breast examination is not recommended. Does that seem strange to you? It is. Because of the false positives that women find, if they are formally taught, it's better just to educate them that they do feel something just routinely on their own that they should report to their doctor. Most women do not. Clinical breast examinations are determined not to be effective in many parts of the world, but they're still found to be an effective use here for clinicians to be examining the breast. And some ultrasound evidence that ultrasound is a great adjunct to clinical breast exam, especially in younger women with denser breasts. There are many studies showing that it decreases mortality from breast cancer. Mammography, in your high-income women, mammography is something that is a possible cause for them, but just remember that there's a lot of questions being raised about mammography, and it should only be done every other year, and it should only be done in women of the age of 45 or older, the current recommendations from the American Cancer Society. Because women in India get breast cancer at a younger age, the recommendations are to start clinical breast examination and education at the age of 30. My last question is here, when you look at the specialist guidelines, all of them are more aggressive about cancer screening. If you look at the OG guidelines for cervical cancer screening or breast cancer screening, they are to do mammograms every year starting at the age of 35. Primary care guidelines are very different. National guidelines are very different. Why is that? Is it because the OGs don't love their patients? They want to harm them? No, that's not the case, is it? They all want to do the best by their patient. But there is a different perspective, right? When you think of the urologist who's sitting there with his patient looking at them, the urologist, all he's seeing all day is prostate cancer. But when that patient's sitting in front of me, there are so many other things that I could do to address that patient that would have a bigger impact on his health. And someone actually did a study and found that it would take me 7.5 hours of talking to that patient to address depression screening, alcohol screening, drug screening, coronary artery disease screening, hypertension screening, diabetes screening, all those other things that will have a huge impact on their health. That would have more of an impact on their health than prostate cancer screening. So in conclusion, I'm sorry I'm running over. Cancer screening is complicated, but it's very, very important for part of our practice. And I just want to encourage you to really be careful about implementing cancer screening strategies from other parts of the world that are not proven and that can be dangerous to your patients.